I wanted to introduce our two trailblazing patrons, Simon Opher, who lots of you will know, who's led on social prescribing and all sorts of things, and Cathy Stannard, who leads the pain transformation programme for Gloucestershire? Bigger, Gloucestershire, yeah. Yes. And so Simon's been working with GL11 on our counselling project to rethink the way the primary care network can fund activities that are happening within the community to support people. And Cathy is working with us also to get real people's voices saying what people really want and need to help their lives living with chronic pain. So, I'll hand over to you then.
Good. Can you hear me okay? We've got a mic here. So.
I think you've got that one. That's the one.
No, that's the one for him, apparently.
Oh, right,
so
okay.
As long as you can hear me, that's great. So, yes, thank you, Indigo. That's fantastic. And can I say what an inspiring leader you are for GL11? So it's fantastic in that way. So, yeah, my name's Dr Simon Opher. I've been in Dursley for about 30 years, and I'm a full-time GP up in May Lane. One of the things that I developed in my career was social prescribing. So after about 5 years as a GP, people quite often come in and say they're feeling sad, or they come in with a mental health type issue, perhaps underlying a physical issue. And I realised early on that actually just doling out tablets is not a good way to deal with these people. It doesn't help them, and it doesn't really help you either. And some people do require tablets, but a lot of people require something different. And so initially we developed social prescribing, and we did some of that with GL11 as well. And social prescribing is when you give a different type of prescription. So you say, why don't you go down to GL11 and volunteer, or why don't you take up an art class, or do some exercise, or go on a walk, go on an organised walk. And actually, the great thing that we found out really quite early on, and Dursley was a real pioneer, national pioneer in this, so we found out that it did make people better. We did science on it, and we could record that people did get better. As they got as much better as they would do on antidepressants without the tablets. So that was a real sort of transformative work that we were doing in Dursley. And then it was about 2000, it was during the pandemic, in fact, that we realised that and I still don't quite understand this, but the pandemic unveiled a huge amount of mental health need in our society. And to be honest, we just couldn't cope in the NHS. Certainly the mental health services couldn't cope. The social prescribers, who are some of us here in the room today, we just couldn't cope. So what we tried to do was actually commission some community-based mental health support. Now that sounds so simple, doesn't it? It was not simple in any way. Trying to fit the right funding stream so you could put NHS funding into the community was a complete nightmare, actually. And actually, it was only because me and Indigo were willing to bend quite a lot of rules that we got it going. And we felt it was okay to bend rules because it was for the benefit of the community. So anyway, after a lot of shenanigans, we managed to develop a mental health. We weren't even allowed to call it mental health, were we? Because that had another set of rules around it. But anyway, we managed to get some health money into a community setting in GL11, and we got patients who were initially assessed in the surgery and then taken down from the surgery by the assessor, by the therapist, down to GL11 for their follow-up therapy. And that has a number of things. So people are quite nervous about getting sort of therapy and mental health treatments outside of the NHS, and particularly outside of the surgery. So this was a way of drawing them out. And then when they got to a GL11, it wasn't just the therapists that really helped. There was a lunch club they could go to. They were meeting friends and maybe just developing a relationship, so they shared lifts to GL11, tiny little increments to their health, which were absolutely enormously effective. And so by commissioning GL11 for mental health type counselling, we actually got a load of add-ons as well. So from just being a stingy NHS commissioner, it was brilliant value actually, and that's where we're coming from. The difficulties with funding remain, and often they keep giving us new rules to work around. but it was really transformative, and it was about getting people away from health settings and realizing that to make people better, you have to make people better, not just medically or psychologically, you have to make their whole lives better, because you can't treat something that's caused by something that's happening in their lives without helping them in their lives in the first place. So it was a real change for us, in the same way as GL11 changed from being that sort of community support to being something else. For NHS, it was a massive change as well. So it really exciting, and something that we've been really working with. And I'd like to leave it there, because this is the point I would like to introduce Cathy. Now, Cathy is one of my clinical heroes, and she actually is a national leader in chronic pain, although she won't say it herself. And that's because she understands chronic pain is not just about the pain. So if I could pass over to you, Cathy, if that's okay.
Can you hear me? That's great. Thanks, Simon, for that, and echo how wonderful and inspirational Indigo is. So just to sort of try and get everybody on the page about why I'm sitting here and talking with Simon when I might be perceived as usually sitting in an ivory tower talking about pain in a hospital. I was a pain consultant for about 23, 25 years in the NHS. And two things struck me. On my first year of being a pain person, it struck me that nothing that we were doing was working. And then it struck me that everybody that came along to my clinic had a lot else going on. And I think we used to frame this as thinking that obviously if you live with chronic pain, which is a really tough gig on all sorts of levels, it has an effect on your sleep and your mobility, you become isolated, all those sorts of things, you may become out of a job. But actually what we began to realize was these things work both ways. And lots of stuff happening in life, past stuff or current stuff, actually directly influences the experience of pain. So it doesn't mean it's in your head, it actually means it hurts. And the experience of pain can be triggered by me, stabbing Simon in the thigh, but also if I gave him a profound emotional trauma, he might feel that as actually hurting. So it's not to dismiss it, it just actually hurts, but actually giving medicines that stop injury signals aren't going to work. And I think in this sort of emerging environment of thinking more holistically about why people come and access services, pain is a perfect example, because people's lives often have a whole load going on and it affects all their relationships and the people around them. But somehow we've managed to build this system where it's focused down into one word. So if you ask anybody with pain, they've got loads more going on than just pain. But we've kind of articulated that as a kind of society. And then what do? You go along to a doctor, you go along to see Simon. And when you go to your doctor, you are trying to be a good patient, so you're trying to frame your problem. You don't think, well, I can't go to Simon about my overdraft, but I'll talk about my pain. And so you kind of focus your ideas into a kind of, it's this game that you play, you just kind of put it all together in a medical way, and Simon plays his medical role. And then everybody's dissatisfied, because that's not going to work. Because what you need to do is just what Simon needs to find out, and what you need to do as a person with pain is talk about your life. So it's not what's wrong with you, it's what is your life like? How's your life been like in the past? What's it like now? What losses have you got? Tell me what is going on in your world. I need to understand your world. And how we came with G11 was kind of slightly odd. So we got some money that sort of came from behind the sofa somewhere a couple of years ago. It wasn't, regular NHS funding stream. And a few places round and about, it started in Australia, but this was an idea that if we could explain the mysteries of how the nervous system works to people, then they could get on the same page as their doctors, and that would all become rosy and we'd be able to manage pain better. And so along those lines, we got some money we're going to go out on a bus and talk about pain receptors and the weirdness of, what causes the experience of pain. And then we had a bit of a think and we thought, well, actually, people don't either need or want to know that. And how can we be so arrogant to be saying, this is what we want to teach you about pain? What we need to do is for the people in the community with pain to tell us what it's like and what they need. And I think a really important part of that was not doing that, going along with a clipboard in the clinic saying NHS at the top, or writing to people and saying, this is your local service, please tell us what you think. So we know those surveys don't work. And people distrust them because certainly every NHS survey I've filled in has never resulted in any change, whatever a bad rating I've given it. So I'm sure that's most people's experience. So we were introduced to GL11 because of the trusted relationship you had with your local community. And we were able to hand over to them and say, we don't want a population of people going to physio or sitting in Simon's surgery. We want people in the community who are living with pain to tell us what it's like, what matters, and what they would like us to do to support as an NHS. And so that's what we did. And Audrey's going to talk about that. Audrey will talk to you about that later. But that has been really, really refreshing. And we have had some really, really important insights about what we should be doing. And what we should be doing is not what we're doing at the moment, which is handing out pills. Because for a start, most people in this group said, stop shoving pills at us and listen to what we've got to say. I think there are challenges, and the harsh reality is that the biggest resource that we need and that people with pain need is time, and time to tell their story. And you just don't, you have to watch the news to know how pressured time is in NHS services at the moment. So we've got to think about, one important thing is thinking about that wider health and care team, including social prescribers, for whom this is bread and butter. These sorts of holistic conversations are what they do, and what they do brilliantly. And if I had my way, I'd get rid of all the doctors who, I'd get rid of doctors and replace the world with social prescribers. But I think that would
hang on.
That would serve a lot of people well. But I mean, when you're talking about life and stuff, actually that's the conversation you need to have. And I often just say to patients, let's just forget you're sitting in the clinic. Imagine we're at a bus stop. And I say, what do you reckon? You've got pain. And the first thing they'd say is, well, actually there isn't a cure because I've had this for 50 years. And I think, but why are they sitting in my clinic? You're asking for a cure. So it's those kind of human to human interactions which are really, really important in that space. And that has been hugely informed by the work that GL11 has done. And I think the other thing is that I'm sure there's a historic relationship between the NHS and community sectors in terms of saying, can you do this for us? Can you provide a, whatever, talking group or something? But actually this is further than that. This is saying, can you find out for us what your community want, and then using that to tell us what we do? And I think that's been quite different, and that's been quite a different way of doing things.
Yeah, no, absolutely. And that, traditionally what happens is we decide what you need and we give it to you. And this is a very different way of thinking. And I think it's really important that actually all medical services take that on because the number of people that, there's something like, if you give a prescription as a doctor, actually a normal prescription as a drug, something like 40% of people just chuck it away. So, and you think that, you get sort of respect as a doctor and they would do what you say, but actually that's because they haven't found out what the patient really wants to do. And I think this type of approach, a more community-based approach, is really essential, for what's going on. The other thing actually is we can't really cope in the NHS at the moment. We've got too much to do. We need help actually. And I think I'm always so appreciative in Cam and Dursley that we've got GL11. And actually GL11 has now been sort of copied all throughout the area, throughout Stroud and down in Wootton as well. And they always say GL11 is the sort of the sort of model that they're working towards, because it does work incredibly well. And it makes people feel better. And that's sort of what we're all into, isn't it? So,
and I think the other thing I'd just like to mention is you've got this case study here, From Patient to Person, it's called. And one of the things that's so important, as Simon's saying, that people go to the doctor to get fixed. And when people come for counselling and then come to GL11 to see their counsellor, it's like they cease to be a patient and become a person. It's sort of the responsibility for their own life and cure shifts from Simon to themselves. And then you can actually do something about it, because you're in control of it yourself. And instead of having Simon shoving pills down your throat, as he's wont to do, you can explore all the other options of what there is and start to, take control of your life. And that's such a key part of healing, because we're not just little victims who need doctors to sort us out.
I think there's a couple of things in here that are really relevant to that. And there's on page, the pages aren't numbered, but there's a thing about the challenge about the things that influence your health and well-being. And 84% of the factors that influence your total health are nothing to do with medicine, whatever. And I think it's slightly, I mean, the health service is overwhelmed, but actually we're spending a lot of time doing stuff that isn't, you know, it's not for doctors, you know, our training doesn't help us do the sorts of things that Indigo does, you know, so it's sort of, it is helping out, but it's also more appropriate services for people. And I think the other thing is about, you know, I think there's a lovely thing in here, Indigo, about poodles. Where is it about poodles? So, and you know, and it's about, you've got to spend time getting to the back of it. So, there's a model, as Indigo's put here, that you have a public meeting and you say to everybody, okay, what would you like Gloucestershire to do to help your pain? And Indigo uses the example of, they say, we all want a poodle. And you think, well, that's not going to fly in the NHS, because, you know, who's going to write that business case for wanting a poodle? But actually get together and you work together and you start unpacking why people want a poodle. And they may want a poodle because they're isolated. They may think it might get them walking. They may want some love. They may want something that feels safe and secure with them. They may want it to yap at the postman, whatever. But unpacking all that, you know, we can't provide poodles, but we can look at people's isolation. We can look at their mobility. We can make sure that, you know, they feel safe in their houses and so on. So, you know, you have to sort of work at it. And often the first thing that you think of might seem unattainable. But actually, if you see what sits behind that, so that's why I think the poodle example is really good. Because actually there's often things that you can do behind that. But I think the frustration is that the NHS is on its knees financially. Would you agree with that? And I think transformation is hard, because transformation means getting from A to B, but doing that without any money is really difficult. And that's just a problem for the whole NHS at the moment. We know we're doing a lot of things that we could do better, but actually doing them in a better way actually takes money. We haven't got any money, so it's, you know, it's quite complex.
But making it a bit more porous between the NHS and the community. So, I mean, if you like, the NHS is framing things as they want reduced waiting lists, they want to save money, all this sort of thing, and they want really clear impact of everything we do. And we're over here, the community is sort of saying, we want to be listened to, we want to do prevention, we don't want pills, and it's sort of like, underneath those things, when you unpack them, they are the same. And so if we can just talk to each other really effectively, then we can find that middle ground, and which the poodle is the example of, really. It's like, what are we actually talking about here? You with your waiting lists and you with your poodles. Where's the middle ground here where we can actually make things happen together?
And I think that's a good point, and it is about making things fit. So I came into this role in 2016 to reduce medicines, prescribing of pain medicines. Not to take pain medicines off people that are finding them beneficial, that's really important, but to support people taking pain medicines and not making the slightest bit of difference and giving them a whole load of side effects. And for various reasons, not least the opioid epidemic in the United States, there's been quite a focus in the NHS on numbers and prescribing. But actually one of the things that has evolved over the years I've been doing this role is actually, until you build better relationships between people's lives are better, all that has to come first before people feel confident to relinquish their medicines. But I have to be honest that in a way, a lot of the oxygen for this sort of initiative has come from the fact, and we often have to kind of shape it into this is a medicines reducing project. And then the idea would be that if you feel better in yourself and you're more active, you don't need the medicines, but that actually comes quite down the line, and that's sometimes quite difficult to demonstrate in 6 months. But you do have to think cleverly about, does this fit in with an initiative? And they are ultimately for the same things. I mean, they do come down to the same things, but they're articulated by in NHS England in one way and by Indigo in another way.
Yes.
Yeah, and that's what I was saying about how you have to be, and this is something I think which is wrong with the NHS, is that they have very rigid ways of funding stuff. And if you don't fit into that, it doesn't work. So that's why all this bending has to take place for a GL11 and stuff. And we need to change that, actually. That's not terribly helpful in terms of the NHS and getting people better. So we need to, and it's a really boring point, but you do need to make the funding much more flexible so it goes to places where it really works. And the other thing you've got to remember, and this is a real challenge for GL11 as well, is you have to prove that you're effective. Now, no one actually asks me to prove I'm effective because I'm a GP and we've all been around for ages. So they just assume I am effective. But because this is new, you have to prove that it works. And that involves doing really boring stuff like doing scores and taking feedback from people. I'm glad to say the feedback is almost universally positive for GL11. And it's really important that, particularly in these social prescribing type projects, if you don't get that, you can't get the funding next time. So I say that as a warning to everyone that everything you do need to measure, even though it's quite boring to measure. It's really effective to do that as well.
I think that's really important because we're always talking about return on investments, and one of the things we've looked at is medicines, because there's a big medicines bill and a lot of people aren't being helped. But I think there is something, you have to record something, but I think there is a power in people's experience of services. And I think, you build up a library of feedback from some of these services. Sometimes there are scores that are useful, sometimes there are not. But actually, certainly the PAIN project, listening to what the people in the community that Elaine and Audrey spoke to, that's been quite powerful in terms of capturing people's imagination about making change. Yeah. So I don't think we should be frightened about stories.
No.
In the absence of numbers, I think stories are always good.
Stories are always better. My absolute favourite feedback is I've got a picture of an old chap sitting next to his allotment at the Vale Hospital, looking proud as punch with a couple of sprouts, and that's the best feedback for me, and that's when I know that it's been really effective what I do. So stories can take the place of feedback, but you still have to collect the stories, and I would urge everyone working in this field to collect those stories. It's a bit like collecting thank you cards. Seems really silly to do it at the time, but it's good to have a good stack of them actually. So